Last week, we covered a hidden placebo effect that can amplify responses to any med that is started on the first visit. Today, we're going to flip that on its head. I call it the placebo flip, and anti-psychiatrists are going to hate me for this one. It's when patients paradoxically get better after stopping a medication.
Welcome to the Carlat Psychiatry podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kellie Newsome, a psychiatric NP and a dedicated reader of every issue. Imagine you have a chronic illness like bipolar, schizophrenia, or recurrent depression. You've been to the doctor for a few episodes, but each time you manage to convince yourself that it was just a temporary reaction to stress. After the fourth episode, though, you start to accept something a bit more dreary. This is your life. You're not like the other people. You have a chronic mental illness, and you're going to have to stay on a medication to remain well. It's a tough pill to swallow. But to make things worse, that feeling of wellness never really comes. Yes, you are no longer in the hospital or in bed all day, and you can hold a job, though not at your educational level, but your mind is slowed. You get anxious for no reason, and you are so fatigued sometimes that it's an effort to move. It's been like this for a few years, and your doctor says that you are in recovery, but you start to wonder if your medication is causing some of these problems. Your doctor is nice, but a bit too optimistic, and maybe isn't telling you the whole story. So you stop your med. The first day, a little withdrawal, no big deal, you can handle it. After 5 days, that goes away, and surprise, you aren't falling apart. You can make it on your own like everybody else. That tale you've been telling yourself that there is something fundamentally wrong with your brain is not true. You didn't need that med. Imagine what else you can do, and you do. With this newfound confidence, you reconnect with old friends. You put in an application for a promotion. Life has finally opened its doors. 3 months later, you start to feel off. Your wife starts to complain that you are detached, that you act like she's not there. Disagreements turn to argument, and soon you're sleeping in separate beds. That's when you notice the depression coming back, and you call up your doctor.
When that patient comes in, he's not likely to ask to go back on the antidepressant he stopped 3 months ago. That med did nothing for me. I felt better after stopping it. I'm only depressed now because my marriage is on the rocks. Maybe the patient is right, and maybe it was just causing side effects all along, but keep in mind another possibility, the placebo flip. Just as patients feel better when they finally have a helpful clinician to lean on at their first visit, they can also feel better when they realize they can do it on their own, when they stop a preventative medication. Most of the time, the new episode doesn't come on right away. It takes a few months. In the lithium studies, it was 6 to 12 months for new episodes to come on. And often, stress tips the balance. That stress may have been caused by early signs of the episode, like the avoidance and disconnection with the wife in the case that Kellie just described. Or it may have just come on. Stress comes out of nowhere. Most of my patients go through some kind of stress a couple times a year, as do most people. So there's always stress to point the finger at. Let's pause for a preview of the CME quiz for this episode. You can earn CME for each episode through the link in the show notes. Which antidepressant augmentation strategy reliably prevents recurrent unipolar major depression in controlled trials? A. Lithium. B. Second-generation antipsychotics. C. Lamotrigine. Or D. Tricyclic antidepressants.
You need to be a little skeptical when patients say they felt better off their med, especially if you carefully reviewed side effects beforehand and didn't find any, and especially if they relapse within a few months of stopping it. One medication where I see this a lot is Siloxane, lavender oil extract, which is used as a prescription for anxiety in Europe, but available over the counter in the US. Unlike most supplements, this one has a large effect size, around 0.8 in generalized anxiety, much more effective than paroxetine in a large head-to-head trial. A lot of our readers have started recommending Siloxane after reading about it in the Carlat report, and if you're using it, here are 2 tips. First, the most effective dose is 160 milligrams, which is 2 capsules. A lot of patients make the mistake of only taking 1. You can give it all at night or space it out twice a day. Second, you'll see a lot of placebo flips on this one, because patients are more likely to stop over-the-counter treatments than the ones we prescribe. Siloxane takes about a month to work, but it might take longer for the benefits to wear off, as I often see people come in with higher anxiety about 3 months after stopping it. When I talk about going back on, they're skeptical, saying they felt just fine after coming off. So I'll show them their own anxiety rating scales, which usually show a pattern of improvement on it, then worsening off.
There are 2 things to know about the placebo flip. One is that psychologically, patients may have a boost of confidence and better mood when they are able to stop a medication. The other is that relapse is usually delayed. For someone with bipolar disorder, there's a 95% chance that they will relapse after stopping a mood stabilizer. But that 95% figure is over the next 5 years. They don't relapse right away. In bipolar disorder, the average relapse happens 6 to 10 months after coming off meds. The longer they were well before stopping, and the slower they tapered off the med, the more delayed the relapse.
But people can go into relapse fast if they stop lithium all of a sudden, right?
Yes, we're often taught that about lithium, but the rapid relapse they're talking about there means 3 to 4 months after stopping lithium abruptly. If people come off lithium slowly, over a few months, the time to relapse is around 10 months after stopping it. Patients do not consider 3 months to be very rapid.
What about with antidepressants?
After stopping an antidepressant, about a third will relapse in 6 months, and half will relapse after a year. So again, we're talking about delays that are so long, patients are unlikely to connect these new episodes with stopping the med. I also see the same patterns when patients stop psychotherapy, exercise, or any lifestyle change that can improve mood. They don't feel worse right away. If they did, they'd never stop these things. Instead, it's several months later that they come in more depressed, and by that time, they have trouble believing it was because they stopped going to the gym 4 months earlier.
The bottom line, when your patient stops a med, there's a long delay before relapse, about 3 to 12 months. By that time, they are unlikely to attribute it to coming off the med, and instead, they may come in telling you that they felt better after stopping the med. This is one reason you need to ask directly about side effects and document them while they are on the med, because unless they had some awful side effect that went away off the med, their sudden improvement in mood may be the other side of the placebo, the confidence boost of the placebo flip.
Now for a research update, and this one you can use in your practice right now. Those of you who've heard me talk on antipsychotics know that I'm skeptical of their use in major depression. Why? They are only approved for short-term use in acute depression. And that matters because the FDA was considering their short-term risks, weighing that with their benefits when they gave us the green light to use them. Sure, the companies tried to get approval for maintenance treatment in major depression, but they failed to prevent depression in most of the industry-sponsored trials. Contrast that with lithium, on the other hand, that one does prevent depression as monotherapy and as augmentation in unipolar depression. It did so in 21 controlled trials lasting an average of 2 years. But this practice with antipsychotics and depression is the reverse of what the FDA intended. We're not using them short-term. We're using them in people who have chronic and recurrent depression, and they are staying on them for years. And as those years build up, their benefits shrink and their risks increase, particularly metabolic and tardive dyskinesia. All right, enough of my ranting. I got one more problem to focus on, and that's where this new study comes in. because we are not doing a good job at detecting those two things. Only about half of patients on antipsychotics get metabolic screening, and around half get Ames screening for tardive dyskinesia. The result is vast underdiagnosis. Take this 2022 study that was done in the public sector where the problem of TD is more common. Only 1% of patients on antipsychotics were diagnosed with TD in that study, while the actual rate with long-term use is 20 to 30%. Yes, even with the supposedly friendlier second-generation antipsychotics, 25% of patients will develop TD on them after a decade of use. Our study of the day hopes to change that. Anthony Stearns and colleagues tested whether an AI-driven video app could detect TD as accurately as trained clinicians in 3 samples totaling 356 patients on antipsychotics. By the end of the study, the 4 human raters, 2 PhDs and 2 MDs, found themselves out of a job. The video app actually performed better than the human raters, with an area under the curve of 0.9, which means it rarely misses the diagnosis and rarely makes a false positive. By the way, it's rare that we see areas under the curve that high in psychiatry. During the trial, the senior investigator, Owen Muir, actually discovered that he had tardive dyskinesia from past antipsychotic exposure for mood disorder. Dr. Muir hosts the Frontier Psychiatrist podcast and spoke about this experience in his April 2025 episode. Very good one. So that definitely brings it closer to home, which is where this app needs to be. The app, TD Screen, is free. The study paid for by a grant from the NIMH. And there's a link to the app on my website where you'll find other evidence-based apps that you can use in practice, chrisaikenmd.com/apps. Put it to use, and it'll vastly increase your detection of TD and improve your charting and documentation, and even your medical billing. You can bill more 99214 if you detect side effects and chronic problems. But if you do put it to use, I don't think it's going to be straightforward and easy. Nobody likes to go looking for bad news, not us and not our patients. So you're going to need to encourage patients to use the app and check in on them or use it during session when they're in the room with you. Cobenfy is a new antipsychotic, but is it safe to combine with other antipsychotics? And does it make them work better? Find out in our June-July issue of the Carlat Psychiatry Report, where you'll also learn about a new clozapine risk that people can prevent by titrating it slowly. Get $30 off of your first-year subscription with the promo code PODCAST and help us stay free of commercial support.